Well, I want to introduce Friso Vries, one of our PhD students, who will give an overview of the work that we in the Leiden University Medical Center have been done the last 4 or 5 years. And the origin of this work started when we wanted to make value-based healthcare pathway in pituitary care. And that resulted in a broad way of holistic thinking in patients' care, patient trajectory. And we would like to share our journey with you today, to provide some ideas and to open discussion with other centers how they have been developing and organizing their care. So Friso, thank you so much for making this presentation. We're looking forward to hear you.
Okay. Well, thank you for the kind introduction, Nika. And as already stated, I will try to give a brief overview of the work that's being done in the Leiden University Medical Center over the last couple of years on the front of value-based healthcare and its integration in pituitary care. I'll be presenting my work and that of many of my colleagues, and I hope it's a nice overview. To start off, first, what is value-based healthcare? Value-based healthcare is a concept introduced by economist Michael Porter that states that with the growing age of patients in recent years and a growing healthcare costs, there's the need to increase the value of healthcare by improving health outcomes and cutting unnecessary costs. And he has put that in a concept that he called value-based healthcare. One of the central points of these of this concept is critical self-evaluation and an overview of your care process and where value is located and what outcomes are valuable for the patient and which expenses can be cut without reducing value. One important example of this value-based healthcare is centralization of certain interventions and medical care, as increasing experience with costs can aid the physician in getting a perspective on where costs can be cut and where outcomes can be improved. So first, we will focus on health outcomes in pituitary care. The original model proposed by Porter et al. Is a 3-tier model. And the first tier is survival and degree of health or recovery after your disease. The second tier that's important for patients is the time to recovery and the time to return to normal activities. So how much time is taken up by disease and loss of healthy years is important there. And the disutility of care or treatment process, so just like a long workup, diagnostic workup before the diagnosis is set, or complications of treatment is important in this tier. And the third tier is sustainability of health. So how often do recurrences occur, and how do these recurrences affect the patient? For patients with pituitary disease, the whole disease process is quite complicated and is affected by a lot of different symptoms and factors like tumor size, the symptoms of overproduction or hormone deficiency. Some patients have vision loss that severely affects quality of life, and tumor extension to other to surrounding tissue can also affect the quality of life of patients. A nice overview of what affects a patient's quality of life is the Wilson-Cleary model. That's a biopsychosocial model that incorporates a magnitude of factors in what affects the overall quality of life of a patient. And one of my colleagues, Cornelie Andela, has made a specific Wilson and Cleary model for pituitary patients and factored in all kinds of processes that affect these. So like for different pituitary diseases, it's very important how a patient, the symptom status of the patient, so like the weight gain that people can get in acromegaly or Cushing's disease, but also cognitive functioning and sexual functioning in prolactinoma patients. And the environmental and patient characteristics can influence the functional status, the general health perceptions, and overall quality of life of these patients. So is a patient able to function and have a full-time job? Is the patient, does they have a durable relationship and family members that can aid them in their disease process? And all these factors influence the quality of life. She has also made a systematic review of all quality of life studies in the pituitary field. And as you can see, patients, which is the small dotted line with active disease in all pituitary tumor fields, have a severely decreased quality of life. The further outside, the higher the quality of life. And you see a decrease in quality of life in all these patients as compared to a healthy sample. When patients are in remission, quality of life improves. And as you can see in particularly figure C, that's our non-functioning adenoma patients, and figure D, which are prolactinoma patients, the quality of life scores approach that of the healthy sample. However, for acromegaly patients, even in remission, the quality of life is still decreased. And this is especially so in Cushing's patients that improve a little, but still have a severely decreased quality of life, even in remission. These quality of life numbers are measured on a generic short forms 36 score, which is used in a lot of medical research on health-related quality of life, but does not encompass all pituitary-specific problems patients can have, and does not give a full overview of all the problems these people can have. And therefore, she set out to develop and validate a specific pituitary disease questionnaire, which is called the Lijden, Bother, and Needs questionnaire for pituitary patients. Here you can see a brief overview of her of the resulting publication around this work, and on the left you can see the different disease concepts that bother the patients the most, and on the right you can see the highest need for support that patients report during the study, during focus groups and questionnaire research. And the highest needs for support were in fatigue, but also in the understanding that patients are very afraid that the pituitary tumor will recur and treatment has to be restarted again. Also, they are very worried about physical symptoms and if they will ever regain their full function. On the bottom, you can see the scores and in need for support, and patients report a highest need of support for physical and cognitive complaints, followed by negative illness perceptions. They seem to be less bothered by issues in sexual functioning and issues in social functioning. The need for support is lower in those categories. And so but now we on the results of these questionnaires and focus group, we constructed a questionnaire that can be sent out to all patients to eventually report in a score on how much patients A, are bothered by their disease, and B, need support from a physician on those bothers during their disease process, and thereby they can follow in how much they are affected at any point in their disease. We implemented these questionnaires in our own clinical care, and on the top you see the outcomes of a patient with Cushing's disease before treatment. The results are in Dutch, so I'll walk you through them. In the blue group is the total bother, and in the green group there's the total need for support. The totals you can see on the top and on the bottom are a summary of all symptoms and groups. As you can see, the higher the score here, so the further outside of the center, means the more bother or the more need for support a patient has. So this patient especially has a high bother from decrease in social functioning, which are the one right next to the totals on the left side, and in mood problems. On the bottom, you can see the results after treatment, and the dark blue dots are the results directly after treatment, 6 weeks after treatment, especially to be specific, and the light blue dots are the results 6 months after surgery. And in these patients, you can see there's a decrease in bother and there's a decrease in need for help, but the results were initially better than after 6 months, which is typical for Cushing's patients, as they're relieved, their symptoms are remitted, and after a while they start to realize that they still have residual complaints, and that these residual complaints will influence their lives for a while to come. And with these results, we counseled the patients on what she could expect and what functioning she could expect for the coming years. And we could counsel her and give her specific psychological help to help her in situations and influence her illness perceptions.
Yeah. Friso?
Yeah.
Thank you so much for this start of the presentation. So I think it's very important to highlight that when you want to do value-based healthcare, it starts with a care path, and we defined the care path as the perioperative trajectory, and so that was diagnosis up to well, 6 to 12 months after surgery, and we included all pituitary patients, and then we wanted to think about well, which patient-related outcomes are important. So Porter made those 3 tiers, and because pituitary is very rare disease with very low mortality, things as quality of life are very important. And not only the general health-related quality of life, but also this disease-specific quality of life as specified. What is also very important is that we were able to introduce the quality of life values in the outpatient clinic. So it's not research-minded only, but it's also clinical care. Do you want to add something, more?
Sorry?
Do you want to add something?
No, I thank you. I think we can continue, because I think the rest of the presentation incorporates your remarks fully.
Thank you.
So
yes.
Shall I continue?
Yeah,
okay,
sure.
So as Nienke was saying, the quality of life in these patients is especially important, and so we looked into factors influencing those, and one of those is social functioning, but also ability to work. That was very important in patient self-management and self-efficacy. Daniel Lobato did a study on the determinants of a paid job and also the problems pituitary patients experience during functioning in a paid job. As you can see here, a lot of patients with pituitary disease that participated in the study had problems during their work, and there were a lot of specific aspects that at least 10% experienced problems with. And if we looked at patients reporting some problems, this was over 30 to 40% in most aspects of work. The determinants of a paid job were status on relationship. So people that were alone and didn't have a partner that could support them were more likely to not have a paid job. Also, acromegaly and Cushing's patients were less likely to have a paid job. Patients that had pituitary deficiencies after treatment and patients that were treated with radiotherapy were less likely to have a paid job after their treatment or during their treatments, during ongoing treatment. So these patients, especially so with acromegaly and Cushing and treated with radiotherapy, should be counseled that it might be hard for them to regain full function and regain their paid job at the level they were before they were diagnosed with their disease. Then I'd like to focus on pituitary surgery specifically, as the Leiden University Medical Center is specialized in pituitary surgery and performs over 150 skull-base and pituitary operations per year. This is one of the focus points of our research. The main focus of the thesis of Daniel Lobato was to introduce value-based healthcare in pituitary surgery and the perioperative pathway. And he used a full set of questionnaires for this. First of all, he made the model of Michael Porter specifically for pituitary surgery. So he adapted the original model and said, okay, so in tier 1, first of all, there's survival. That's of course the same for all diseases. But what is the regain of function and quality of life in these patients? What are determinants? Well, endocrine remission, visual recovery after treatment, and recovery of pituitary function, but also degree of resection, because this influences the further treatment and in what way patients are done with treatment after the first operation, but also the recovery in health-related quality of life. He constructed an overview of the care pathway. This is a bit fast. I will have a slower overview later in the presentation. So he made an overview of the full process, or perioperative process for patients, and made measurement points to question them on their quality of life, to introduce and value of healthcare, to see how we could incorporate value-based healthcare in this process. First, I'll focus on the clinician-reported outcomes, which is degree of endocrine remission, but also complications. So as you can see, these are our numbers. On the left are the remission numbers after surgery for functioning pituitary adenoma surgery. So about 65% is in remission after surgery. These are all surgeries, so also reoperations, fourth operations, and operations for apoplexy or giant adenomas. And the highest chances of remission are those in patients with prolactinomas, and the lowest chances of remission are those with acromegaly. On the right is the list of complications. And as you can see, about 6% of functioning pituitary adenoma patients experience a long-term complication. And long-term complication is defined in this case as over half a year. So over 6 months, they experience this complication, and it's often lifelong. In non-functioning adenomas, this number is a bit higher. This is just below 10% of patients. And the most experienced permanent complications or long-term complications are new anterior hypopituitarism and permanent diabetes insipidus. Other long-term complications are permanent anosmia and neurologic complications due to vascular complications, such as bleeding in the resection cavity or a carotid injury. Mortality in this procedure is particularly low, with only 1 patient in over 400 treated and studied patients that deceased after treatment specifically related to the treatment. And this overview is specifically important when counseling patients that undergo elective surgery to weigh their the benefits of the disease, so possible remission or decrease of symptoms to the possible complications and negative outcomes of treatment.
Friso,
yeah.
Maybe when we are discussing counseling of patients, which is of course very important, and you want to have the patient like me. So the patient that's well, similar to your situation. And then, well, we of course see that the acromegaly patients, the cure rate will be very much dependent on the size of the tumor, for example. And the same is true for other tumors. And so these numbers, they're usually the numbers in the papers. Well, but in the outpatient clinic, you want more specific data. Do you agree with me?
Yeah, certainly. I will focus that on in a couple of slides. I will come to that.
Okay, thank you.
Yeah. So these are the clinician-reported outcomes, and these are still very hard to interpret for a patient. So 6% long-term complication, what does that mean for me? Well, it's likely for me to be in those 6% or not. And what's possibly even more difficult to understand is the health-related quality of life outcomes in patients, but it's nice to give you an overview of those. So these are outcomes of different questionnaires in the perioperative process from pituitary patients. With the downward triangles, you see the prolactinoma patients. With the upright triangles are the Cushing's disease patients. The squares are acromegaly patients, and the circles are non-functioning adenoma patients. On the top left corner, you see the course of the Leiden-Bodmer needs questionnaire. And the higher the score, the more symptoms the patients have. And in this questionnaire, you can really see the effect of treatment nicely. So you see after baseline, in all categories, disease groups, the total Bodmer score decreases. And in the especially in the prolactinoma patients, there is a stark decrease in the Leiden-Bodmer needs questionnaire score that decreases even after 6 weeks, even further up to 6 months. You see that the complaints remain relatively stable in the non-functioning adenoma and acromegaly groups. Other reported other diagrams are those of more generic quality of life measurements. So like the short form 36 Bantle component, that's diagram B. And there you can see, especially for prolactinoma patients, that there functioning on the mental component increases after treatment, and the rest of the disease groups remain relatively stable.
And increases here is improvement.
Yeah, yes, exactly. And then for the negative effects of treatment that are mainly nasal morbidity, we can, the results of this study showed that most of these symptoms are, fortunately, are transient. So you see a stark increase in symptoms on the two questionnaires on nasal morbidity 5 days after operation, that normalizes after 6 weeks to 7 months. So the negative consequences on the nasal morbidity are luckily transient.
And maybe it's good because this is the shim that we chose to analyze during perioperative care. And so there's a combination of the morbidity after surgery. So symptom score, they're generic questionnaires, and they're not that sensitive in comparison to the disease-specific ones. But what is very important is that we also like to compare pituitary diseases to other diseases, other endocrine diseases, but also other aspects. And for example, the EQ 5D scores are quite good in comparison to other severe chronic diseases. And it's important to realize that you're very dependent on the population what is wise to use. And I really think it's important issue of Endo ERN and future consensus meetings to find out which is the best score to use in this patient group. So this was a first initiative, and we know there are other initiatives, but it's good to discuss what is best.
Yeah, and what's best will be different in specific uses. So if you want to indeed compare it to other malignancy or chronic diseases, you might want to use in the short form 36 or the EQ5D. But if you want to compare patients within their disease scores, the LBNQ might be better, as you can observe the most differences during the disease course and perioperative course in the diagram depicting the results of that questionnaire.
Yeah.
Then onward to the patient like me. For a lot of patients, when you want to counsel them, these diagrams and outcomes are abstract and hard to get an overview from and make a good a personalized decision from. And therefore, we wanted to get a simplified expression of all the results, incorporating patients' results important for the patient. And we focused on first on functioning pituitary adenoma patients, as the result of treatment that you're striving for is often remission or is often remission, and that's easily measurable for most patients. And the other thing you're striving for is there's no adverse effects of treatment. And if you integrate those two functions, so remission versus non-remission and adverse effects versus no adverse effects, you get 4 outcome groups, which we call integrated outcome quadrants, with on the top right no remission with no adverse effects, which is good outcome, and the best outcome of surgery or any treatment, which are striving for 2 intermediate outcomes, so remission with an adverse effects or no remission, but also no adverse effect of treatment, and the poor outcome. So patients experience a complication of treatment, but do not gain remission. And that's the category to avoid. When we were constructing this outcome scheme for patients, especially the surgeons weighed in and said, well, it's a very nice thing you're trying, but remission is not always the thing we're aiming for during a surgery, and this might make our results look worse than they are, especially in large adenomas, functioning adenomas. You're maybe not looking for remission, but an other intended effect of surgery, like being able to gain biochemical control with medication that is lost beforehand, or decompress surrounding structures of the tumor, and not to perform a gross total section and put the patient in remission. So we also made a second presentation, which didn't integrate remission and adverse effects, but intended effect of surgery. And it's very important for that outcome classification that a patient is personally counseled for what is his personal goal of surgery. What is the intended effect of surgery? Is it to gain remission, or is it to perform a debulking to gain biochemical control or lower medication dose, and integrate that with adverse effects of treatment. The adverse effect of treatment that we deem most important is long-term complications, so complications that are longer than 6 months or lifelong, as these affect especially endocrine deficiency, decrease quality of life of patients. And when we present these outcomes of patients in a simple circle diagram, this is the result. As you can see, more than half of the patients experience remission without a complication, a long-term complication, more than half. But there's also about a third of patients that does not gain remission and does not get a complication, and the remaining patients either fall in the category remission with a complication or in the poor outcome, so no complication, so no remission and a complication. Where we integrate intended effect of surgery, outcomes look a little bit better. About 3/4 of patients achieve the intended effect of surgery without a complication. So those numbers are quite good. Also, we have to counsel patients that there's a 25% chance that they will not achieve the intended effect without a complication in either of the 3 other categories. The outcomes look a little better for non-functioning adenoma. So this is only as there's no full measurable remission of non-functioning adenomas biochemically. We only integrated intended effect and adverse effects, and then you see a very favorable outcome pattern in these patients. And we use these diagrams in the outpatient clinics. However, we want to focus on the patient like me. So we made specific diagrams for disease groups, but also for tumor sizes and whether it's a first operation or a reoperation. So as you can see, the outcome pattern for prolactinoma patients is quite favorable compared to patients with Cushing's disease or acromegaly. Microadenoma and macroadenoma does not have an effect on outcome pattern when intended effect is used. When you only use remission, the outcome pattern is obviously a little bit better in microadenoma patients. However, even when you look at intended effect achieved after operation, the outcome of surgery are worse in the reoperation group. So patients that are counseled for a second or third or even fourth operation should be counseled that their chances of success are lower than those of a first operation, even when it's not to when the intended effect is not to gain remission. Then the second part
Maybe,
of this presentation.
So can we go back one moment? Because we think the dark gray category, which is no remission achieved, but also no long-term complications. well, it's about how to judge those procedures, because we, on the one hand, we think, well, we did no harm. Of course, you want to optimize your situation, and in the development of our care path, one important issue is to try to, well, improve the long-term complication rates. And of course, the second aim would also be to improve the procedures without achievement of the intended effect. Do you agree with me?
Yeah, of course.
Yeah.
Yeah.
And one thing that is quite interesting is by using the combination of adverse effects and intended effects, we are able to, well, every few years you can compare your data and see trends. And of course, you have to interpret with a lot of caution, because the numbers are too small to do formal statistics. But it's important when you want to assess your own results that you have a strategy to also look at small numbers.
Mm-hmm. Yes, that's very true. And that those periodical evaluations I will show a bit later in the presentation. So we use these circle diagrams not only to counsel patients, but also to assess our own results, as Nika just stated. Well, this is the outcome part of our research for the last couple of years. There's also work in progress. But value-based healthcare does not only focus on outcomes, but also on costs of healthcare and cutting unnecessary costs specifically. But first, to cut costs, you have to have an overview of the determinants of costs and healthcare utilization. And for now, we've been looking into the costs and healthcare utilization in non-functioning adenoma patients. That's on the left. And in prolactinoma patients, that's on the right. And as you can see, most costs in non-functioning adenoma patients are health professionals, so consultations and hospitalization costs. However, in prolactinoma patients, the most important denominator of costs is medication costs. And then we also looked in not only what are the direct sources of cost, but what are the determinants. And then we saw that in non-functioning adenoma patients, age was a higher age meant more costs, but also a lower quality of life increased costs. And also marital status and relationship status. Patients that were alone were more likely to have more healthcare utilization and increased costs. And we saw the same pattern for prolactinomas. However, there was also an increase in healthcare utilization and costs for patients that were not in remission, as can be expected. We're now currently are looking into the costs of the perioperative care at the moment, and I hope we can present these results in a future session. Then it's very important to evaluate provided care and to incorporate learning points of those analysis. So first of all, centralization. As you can see here, over the last 6 to 7 years, the number of pituitary operations has increased dramatically in the LUMC. So where in 2014, about 50 operations were performed in the LUMC, it's now over 150 per year. And those are the skull-based lesions and pituitary lesions only. And that helped us, this growth and centralization, to set up a critical evaluation of the care process. So here's a first approach to which physicians and which processes are involved in which stages of the perioperative trajectory for a patient. And thereafter, we made an overview in a diagram that depicted the patient's care pathway. It will start in a second again a bit. It starts at the moment the patient is without a diagnosis and is still in regional hospitals trying to find the source of their complaints. Then they're waved to the academic center and further diagnostics. Eventually, they will be discussed in a multidisciplinary team, and then they will be counseled on which options they have for treatment, and such as surgery or medication or radiotherapy, and even beyond that, further treatment options such as, can a patient have a short admittance, or do they have to be admitted for long after treatment, and can they be monitored at home? Can they use an app to connect with a pituitary case manager to record their complaints and discuss possible interventions? So, and this overview of the care process was very important for us to look for optimization projects. So this was mainly our first step in the right direction and integrating value-based healthcare. Then we've taken a close look on decision making in pituitary surgery, and what choices influence the ultimate decision to perform surgery or propose non-surgical therapy, such as medication, prolonged medication, or radiotherapy treatment. And first of all, it's important if the surgeon assesses if there's a harmless complete adenoma resection is possible. If that's likely, of course, you're going to propose surgery, because you can give a patient lifelong remission of their disease with low risks. But if it's only potentially, so there's a lower chance, you have to weigh the risk of complications and the need for surgery. So are there other options, therapeutic options, and how heavy is the disease load for a patient? Even if harmless complete resection is unlikely, you can look into the fact if partial resection is meaningful. So if we can only perform a debulking, is this meaningful? If yes, then you can still, and you have a low risk of complication, then you can still propose surgery to, for example, gain biochemical control in patients that don't have that, or to decompress the optic apparatus. Then we analyze our own performance, and as we stated before, we've used the integrated outcome quadrants for that in the last couple of years. And as you can see here, on the top are the functioning adenomas. You can see that the outcomes have improved when we compare the 2016 to 2018 period to the 2010-2015 period, which are about 100 patients each, and the same counts for NFAs. And the change is a little bit more dramatic in the NFA section, and a little bit more visible. And this could be to especially the complication rates have decreased over this period. And this is also the period in which we've become a high volume center. So centralization possibly has had a major influence on the improvement of the outcomes of treatment. Moreover, we have, on the basis of these analysis and also scientific analysis, we've performed a couple of interventions in the care process. So first of all, we implemented a self-management program for people with decreased quality of life after treatment, and mostly in remitted patients, to teach patients how to structure their life and be and gain self-efficacy in their disease, and enable them to gain the highest quality of life possible for them with the energy levels and disease symptoms they have after treatment or after treatment. We've implemented an early discharge protocol after surgery with ambulatory consultations with a pituitary case manager to cut the standard admission time from 5 days after surgery to 2 days after surgery to cut unnecessary costs. We made adjustment to the postoperative evaluation of the HPA axis. So for the first evaluation, we now only use a basal cortisol instead of a far more expensive dynamic test that had no added value for patients and management. We've made a standardized and diagnostic approach and treatment for postoperative diabetes insipidus to cut unnecessary costs and unnecessary medication administration for these patients. We've introduced an ophthalmological priority score for surgery, so patients with a high visual morbidity and the highest likeliness to benefit from a swift surgical intervention are prioritized higher than patients than other patients for intervention. We've aimed to provide uniform definitions of provided care with Endo ERN to aid reliability between centers. So we hope to improve reliability and comparability between centers in provided care, so it's easier to apply other interventions that other centers benefited from in their own experience. And lastly, we've incorporated preventive fluid restriction after surgery to prevent readmittance due to SIADH, which was a problem in earlier years. And that also in hope to decrease complication levels and better outcomes for patients, but also to cut unnecessary costs in these patients. There's still a lot of ongoing and necessary research at the moment. So first of all, it's costs and determinants in the perioperative phase. Also, we're trying to differentiate care pathways to specific needs and risk profiles. So again, that's a patient like me or the individual patient. So to stratify patients and give them the best specific care they require in their situation. And we're now collaborating also with medical decision science department in the to analyze the effects of the combination clinic, as we now have a combination clinic for years in which the patient is consulted at the same moment by a specialized pituitary endocrinologist and a pituitary neurosurgeon on what treatment is best for them at that moment, if they should consider surgery or that they should consider a non-surgical treatment option. And we want to measure the effects of this specific consultation procedure on patients and on the choices they make. Also, we want to look into the decision-making in polyclonoma patients, as this is a very difficult group, as many patients are best treated with dopamine agonists, but for a small subset of patients that have a lot of side effects of medication, there's there's a difficult decision on whether these patients are better off with surgery or should continue their medication, and we want to have a look on how this decision process affects these patients and what choices they consider. And we want to analyze the effect of the integration of patient-reported outcome measures in the clinical consultations at the outpatient clinic. That's a lot of work we've performed, and I'm happy to say that for these efforts, we've been nominated for the Value-Based Healthcare Prize 2021. If you want to look up our specific case, you can use one of the links below. And finally, I want to thank you for your attention, and especially thank all of the named colleagues that have put our efforts and work into this journey on integrating value-based healthcare in clinical pituitary care.